네, 안녕하십니까. 건국대학교 조주입니다. 존경하는 김동규 교수님의 오늘 그 심포지움을 이렇게 많이 참석해 주셔서 고맙습니다. 저는 개인적으로 그 퇴임을 축하한다는 말씀을 잘 이해를 못 하겠습니다. 퇴임이라는 말이 단순히 숫자를 그 의미하는 건데 그게 왜 축하를 받아야 되는 건지 잘 이해를 못 하겠고, 저 개인적으로는 그동안 쌓여 있는 많은 지혜와 경험과 그 많은 그런 그 철학을 새로이 그 뒤따라가는 사람들한테 전해주고 깨우쳐줄 수 있는 그런 좋은 그런 그 시작점이라고 생각이 되기 때문에 저 개인적으로는 퇴임을 축하한다는 말씀은 좀 드리기가 어렵습니다. 그렇지만 사실 그 김동현 선생님께서 저한테 많은 그 인스피레이션을 주셨습니다. 특히 정유 기능과 방사선 수술 분야에서는 세계적으로 많은 활동을 하시면서 저한테 많은 지침과 경험을 주신 것을 평생 깊이 간직하고 진행하겠습니다. 오늘 이 자리에 원래 그 데이드 런스포드 선생님이 그 참석해서 강의식으로 돼 있는데 아마 뭐 미세먼지 때문인지 이 자리에 아마 지금 안 계십니다. 그래서 제가 한글로 진행하시는 것을 널리 양지해 주시고, 오늘 그 데이드 런스포드 선생님께서는 비디오로 마샬링 데이터 to challenge the existing paradigms of brain surgery, the triumph of radiosurgery라는 주제로 비디오 렉처를 하시겠습니다. 여러분 잘 보시고 질문에 그 대답을 해주실지는 잘 모르겠습니다. 시작하겠습니다.
Hello, my name is Dade Lunsford. I'm at the University of Pittsburgh, and I'm sorry that I can't be with you for this commemorative symposium in honor of Professor Dong-Gyu Kim, who I understand is retiring as a professor in Seoul. For me, I think it's a great honor to be able to say a few words about the work of radiosurgery, of which he has been a primary contributor over many years. I'm sure he's too young to retire, but that's the way it goes. Professor Kim and the team asked me to talk for a few minutes about how data accumulated over many years has changed the face of neurosurgery, especially related to the use of stereotactic radiosurgery and specifically the gamma knife, which we have used since 1987 at the University of Pittsburgh Medical Center in more than 15,000 patients. I have to give you my conflict of interest as required, and I'm going to talk now a little bit about how data has been accumulated, not just at our center, but across the world at many other centers. In 1987, neurosurgery was perplexed by what was the field of radiosurgery, and this drawing and photograph by my friend Doug Kansioka was exemplified that confusion. The reality is we treat small volume lesions with a single treatment in order to inactivate them, or in the case of AVMs, to destroy them. And over the 32 years that we've been working at the University of Pittsburgh, we've now treated more than 15,500 patients. These include both tumor categories, functional brain surgery, especially for pain, trigeminal neuralgia, movement disorders, and a large experience related to vascular malformations, arteriovenous malformations being number one. So let's talk a little bit about the data and what it means and how it's grown. We know that over the years, the primary management of many patients who present with schwannomas of cranial nerves, especially the eighth cranial nerve, we now use radiosurgery as the primary management. It's an outpatient procedure. It gets patients back to work, back to their regular life in 24 hours, and it reduces costs greatly during the 30 years that it's been done. So we see an example such as this, the type of tumor that we would treat, and then a long-term follow-up which persists over many, many years. And we see that over time, we can see shrinkage of these tumors in the vast majority of cases. One of the interesting things this data has accumulated is that we can see one of the features which we thought was against its overall value was if it had cystic structures, but these are actually the ones that are most likely to show shrinkage over the course of time. And of course, we can use the radiosurgery for older patients with no risks of problems as opposed to open surgery. And this has led to major changes in how we take care of this type of problem, with radiosurgery taking the primary lead in the management of schwannomas at our center compared to resection, which is generally used for much larger tumors. So at 30 years, we can say there's a less than 1% risk of a facial nerve problem, a 50 to 90% chance of hearing preservation, which is related to how good the hearing was before, how big the tumor is. We know that there's a 96% freedom from resection. So in the current world, we can ask really who needs to have surgical removal. It's only those patients who have symptomatic mass effect, trouble with balance, coordination, headache. And what type of resection, if it's going to be done, it should be a limited resection, trying to preserve cranial nerve function, and then using the gamma knife as an adjuvant tool. Similarly, for meningiomas, with more than 2,000 patients of ours treated and more than 100,000 patients treated worldwide, we know that removal of such a tumor in the cavernous sinus is high risk and cannot be completely resected. At best, you can get a Simpson grade 4 resection. And so radiosurgery was developed as an option to try to improve tumor control and reduce risk, maintain function, and we see shrinkage of the tumor over time. In fact, the patients who did the best are patients who had not undergone prior surgical resection in terms of tumor control, perhaps related to the fact that it's easier to plan a treatment for a patient who's not had prior surgery. Radiosurgery has been a game changer for arteriovenous malformations with a high rate of obliteration, more than 80 to 90% of the patients with smaller volume AVMs showing complete closure within 3 years. For trigeminal neuralgia, this has been a very important procedure that is the least invasive management of this problem. It's not as elegant as doing microvascular decompression, and it's an ablative procedure. It's designed to try to affect transmission through the nerve. So we target this using high definition imaging, and we can get very good response. And interestingly, what we found, sort of as we suspect with epilepsy cases, that if we do this sooner in the development of this pain problem, we have a much better response. In this case, if it's done within 3 years of the onset of trigeminal neuralgia, these patients have better initial and better long-term relief. But overall, the probability of relief within 6 to 12 months is very high, with many patients having complete pain relief or BNI grade 1, and others having good control of pain with minimal medical management. The data has been accumulated from multiple centers across the world supporting this particular outcome, and it's well documented as the least invasive procedure, which we would prefer in many older patients who have comorbidity risks for more invasive surgery. We're still looking at ways to improve this particular outcome. And one of the things we recently looked at in our own database of over 1,200 patients with trigeminal neuralgia is that if we can treat the nerve in a way that it gives relief, but without causing much sensory dysfunction, those are the best results. And it turns out that the dose absorbed by the nerve is not simply a single dose based on nerve volume. It actually needs to be in a range of 1.4 to 2.7 millijoules to achieve the best results in terms of both pain relief and sensory preservation. For pituitary tumors, we know that the primary option for these patients is microsurgical or endoscopic. But when the tumor residua is left in the cavernous sinus, early radiosurgery is very important for residual tumors or for certain older patients who may not be a good candidate for surgical removal. So radiation therapy or fractionated radiation therapy is not done anymore. For these patients, we can shrink the tumor, have good tumor control with more than 89 to 90% tumor control at 10 years. And this has been looked at through multi-center studies, looking at various programs that have submitted their data to the International Radiosurgery Research Foundation. So 1 year, 99% progression-free survival. By 10 years, maybe drops to 76%, but some of these patients can have retreatment if needed. And this work, which Dr. Kim has helped to pioneer as well, has really changed the management of metastatic cancer when it reaches the brain. We no longer need to do surgery for the majority of the patients, and it's not important about whether it's 1 or 5 or 10 or 50 as long as we treat them all. We no longer use whole head radiation therapy for the management of this problem. And resection by craniotomy is left for large symptomatic tumors or those that have previously been undiagnosed in terms of their cell of origin. And in that case, we use tumor bed radiosurgery to treat this tumor remnant for prevention of further growth. We know from multiple studies that it's not one, it doesn't have to be a magic number of 10 or 15 or 20. It's equally good as long as we treat each tumor. We use radiosurgery as an adjuvant management in gliomas, especially aggressive meningioma, gliomas grade 3 or grade 4. Almost all of these represent patients who have had progression of their tumor despite initial management, usually with surgery, radiation, and concomitant chemoradiation. So in this group of patients, for example, recurrent glioblastoma seen here and treated by adjuvant radiosurgery, we see that in this group of grade 3 and grade 4 tumors, we can get a 31% 2-year survival in this group of patients. And in the patients who in the RPA class 3, the actual 2-year survival rates are almost 60% of patients. And even in the worst case tumors, glioblastomas in difficult locations, 2-year survivals of 42% when they are eligible for adjuvant radiosurgery as part of the management strategy. Over the years, our group has used publications as a major way to try to spread information and data. We continue to work on this with our residents and our fellows over the course of years, with many publications based on our own database, which comes from a registry that we set up 32 years ago to track these patients. More recently, over the last 5 years, we have now combined our databases for selected cases, and 39 centers are now participating in this research foundation, which started out as first the North American Gamma Knife Foundation, but is now to include other radiosurgical technologies with 39 centers participating on a worldwide basis. And what this does is allows us to take individual problems, meningiomas, pituitary tumors, schwannomas of various types, and combine these into outcome studies with long-term perspective. This is retrospectively acquired data, but prospectively being entered into databases by individual programs. This really allows us to have very good outcome data without the need for expensive prospective clinical trials, which might be higher level of outcome data, but which unfortunately would take high level funding and be very difficult to accumulate data because of the need for many years of long-term follow-up. So overall, the wider and larger database has led to major paradigm shift in the role of radiosurgery across the world. Overall, we see much wider acceptance, certainly among our colleagues, even with governments, health insurers, and national professional organizations, which have continued to put out radiosurgical publications, but also to put them onto their major scientific meetings. It has changed the demographics of the patient database, because 30 years ago, brain metastasis, for example, was not even on the radar screen for radiosurgery, and that represents the largest single use that we have for these technologies in the current world. There are more than 2,000 publications related to Gamma Knife alone, which is certainly the technology which has had the most impact on the literature. Now there are big data pushes. There are corporate professional organizations, there are national registries that are continuing to accumulate data, just as we're doing with the International Radiosurgery Research Foundation. There is still some confusion as to what is radiosurgery compared to radiation therapy. And most radiation therapy has been significantly improved using guiding technologies. But when we do this, at least in the United States, in less than 5 sessions, and we sometimes do more cases now with hypofractionated technique using the icon gamma knife, then this represents a radiosurgical technology. When it's being done in 5 fractions or more, then it's more often referred to as radiation therapy. So there's increasing science. Unfortunately, most funding for this has come from either industry or from limited government funding. In the United States, the National Institutes of Health has not been terribly interested in this, even though it's a huge budget related to cancer management. As a general concept, the addition of radiosurgery, for which Professor Kim has been a great contributor, has greatly increased the options that neurosurgeons can offer patients as part of the armamentarium we have. We need to train our residents in doing radiation-based techniques with radiosurgery. If we don't do that, we're going to lose it as a big part of the field of neurosurgery. So what I found over the years is, perhaps Dr. Kim did in his own environment, is that sometimes your colleagues don't quite understand what you're doing. We give 6 training courses per year. We've trained over 2,500 people here in Pittsburgh related to the usage of the gamma knife. And eventually we will win over more converts. For others, data is what's going to be the answer. So in my 40 years in this realm of radiosurgery, I believe that it's definitely changed the face of neurosurgery. It is driven both by single center and more by multi-center outcome studies. The spectrum of cases that we treat is quite large: benign and malignant tumors, vascular malformations, pain problems, movement disorders. We need to continue to train the next generation to be able to do this and to perform it. Currently in our own center at UPMC, we do perhaps 9,500 cases of brain and spine surgery and peripheral nerve surgery per year. Right now, radiosurgery using gamma knife, cyber knife, and other linear accelerator techniques represents somewhere between 10 and 20% of all the surgery that's being done by our faculty here. We know that these outcome studies have shown that this greatly improves the outcome and management of many difficult neurosurgical problems. It's not an either or in many cases. It's often plus, that is surgical debulking perhaps, followed by adjuvant radiosurgery. It greatly reduces costs while it's improving outcomes. And it's clearly enlarged the types of tools that we have to be able to treat these difficult problems. So the admonition of Professor Lexell, who was the pioneer and father of this particular field, was taken from an old American folk wisdom, and in his last book on Hirnfragment, a fool with a tool is still a fool. We're trying to use this technology in the safest and best way, and we believe that the data that's been put together over the last 32 years will be able to help continue to guide its usage. So I hope that this symposium goes well. I regret that I could not be there personally, and I'm delighted to commend Professor Kim for all of his work in the field, and I hope that the future years are also full of enjoyment. Thank you for inviting me to participate in this symposium.
Thank you, Dr. Lunsford.